Hi, this is Brian Kim. I want to share with you this case of a patient who had negative dysphotopsia in her first eye, and so we chose to perform a reverse optic capture of a three-piece lens in her second eye as prophylaxis for the negative dysphotopsia. But in this case, I made the Rhexis a little bit on the small side, and so you're going to see me struggling a little bit trying to achieve the reverse optic capture. You'll see the maneuvers I did in order to successfully achieve reverse optic capture. So I use a cotton tip to steady the eye and use a corneal marker to help me center and size the Rhexis. I make my paracentesis incision first on the right side and the left side, making sure my incision is flat to the iris plane to achieve a self-sealing incision. Inject some intracameral lidocaine and then some dispersive viscoelastic to fill the anterior chamber. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and just shy of the edge there, I dive in, and that's a triplanar incision. I inject some more dispersive viscoelastic to fill the chamber. And then I go in with my forceps. This is the puncture style Capsulorhexis. I puncture the center, pull down, so you can see I start the flap a little bit early, and that is so that I can have a small size Rhexis. As you can see, the Rhexis is pretty small, and you will see again how I'm going to have a little bit of trouble prolapsing the optic. This is the Capsulorhexis hydrodissection technique. I place the cannula underneath the Rhexis edge contra-incisionally, get a nice fluid wave, decompress, and then I'm rotating the lens on the right side, pointing the tip down, and it's rotating nicely. Irrigating the surface of the cornea, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Remove the surface epinuclear material, place the chopper underneath the Rhexis edge out to the equator, pointing the phaco tip vertically subincisionally, dividing the lens completely in half. That's the double chop. Place the chopper around the right heminucleus, pulling it centrally towards the phaco tip, dividing the right heminucleus. That is a cross chop. Using a little bit of vacuum to grasp that first quadrant, and it prolapses up nicely, and then crushing it with the chopper, and then once it's smaller, emulsifying the lens piece. This is a fairly soft lens. Placing the chopper around the second quadrant, pulling it centrally toward the phaco tip, dividing the second quadrant, and then using mechanical fracturing forces, crushing the lens between the chopper and the phaco tip, and using a little bit of vacuum to position the piece on the tip. Using the chopper to pull that piece up out of the bag, crushing it between the chopper and the phaco tip, and then emulsifying the lens piece. Turning the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally toward the phaco tip, dividing the second heminucleus, placing the chopper around the lens piece again, around the third quadrant. It didn't actually cut it on that move, so I used a little vacuum to pull it up and then crushed it with the chopper. Get the chopper around the fourth quadrant, pulling it centrally, dividing the lens in half, using some vacuum to hold the lens, and then crushing it between the chopper and the phaco tip, and then emulsifying the lens pieces. So you can tell that this lens is on the soft side. Starting to remove the epinuclear material, grasping on the anterior side first, placing the phaco tip deep in the bag to protect the posterior capsule. I take the chopper out, push BSS in, take the phaco tip out, and then I go in with the INA handpiece. I'm going to start sub-incisionally, removing the cortical material from anterior to posterior. You can see the high vacuum really very easily peels the cortical material off nicely. Once I remove the cortex, I switch to polish mode and polishing under the Rhexis edge. It's always nice when you have a 360-degree sheet of cortex, you can peel it from anterior to posterior. You can feel fairly confident that you won't have any remaining large pieces of cortical material. You do have lens epithelial cells, so you do have to polish that. You can have fine wispy material on the posterior capsular surface, and that's why the polymer tip is nice. I can just polish off that fine material off the posterior capsule, just very gently in the polish mode. Once polishing is complete, I place the BSS cannula through the paracentesis, place it underneath the Rhexis edge subincisionally, and I start to pulse the subincisional capsule fornix to see if there's any cortical material. In this case, it was clean. I'm injecting some cohesive viscoelastic to fill the capsular bag, and then I'm going to polish underneath the Rhexis edge of lens epithelial cells. Polish on the left side and then the right side. And again, I'm going to do a reverse optic capture, which means I'll have to widen my incision with the diamond blade. So I'm widening my incision. And I'm going to inject the 3-piece acrylic intraocular lens into the capsular bag. I'm going to point the barrel to the left, which allows the leading haptic to come out planar. It goes underneath the Capsulorhexis edge into the bag. As the optic is delivered, I rotate the barrel 90 degrees counterclockwise, which allows the optic to come out flat. You want to make sure the trailing haptic comes out pointing to the right. I use a Maltzman to dial the trailing haptic into the bag. I go in with the INA handpiece, go underneath the lens, removing the viscoelastic from within the bag. And now you're going to see, before I use a two-handed technique using the cannula and the INA tip to basically tilt it and pop that distal part of the optic up anterior to the Rhexis edge, but because my Rhexis is so small, I'm having quite a bit of trouble doing this. And because I widened the incision, my continuous irrigation keeps deactivating because I have a little bit more chamber instability because I widened my incision. And so I'm fighting flattening chamber as well as that distal Rhexis edge won't pop down underneath the optic. Since I'm not getting anywhere, I decided to use a Maltzman to retract the anterior capsule distally, and by retracting the anterior capsule, hopefully the optic would pop up. And so as I did this, lo and behold, it worked. And again, my continuous irrigation kept deactivating because of the fluid egress, so that was a little bit of a challenge. And so thankfully, I was able to achieve reverse optic capture configuration now. Again, with some difficulty, I was able to do it using the Maltzman to retract and pull the anterior capsule peripherally so it would be wider than the optic. And as I did that, I was able to pop the optic up. So I'm removing all the viscoelastic from the anterior chamber. The learning point is that when I make the Rhexis for reverse optic capture, it is important to make it small, but it's a balance between making it too small or too large. If you make it too large, you won't be able to achieve a reverse optic capture configuration. If you make it too small, you're going to encounter some of the challenges that I had with this case. So again, with the reverse optic capture technique, I'm going underneath the lens with the INA handpiece. I try to pop the distal aspect of the optic away from me contra-incisionally up with the INA handpiece, and then using the BSS cannula, pushing down on the optic proximally to tilt it up. Because of the small Rhexis, I wasn't able to do that, and so I used the Maltzman. I was able to retract the distal anterior capsule in such a way that as I retracted it, I was able to pop up the optic distally and achieve the reversed optic capture configuration. Thankfully, this patient, after surgery, she stated very clearly she did not have any negative dysphotopsia with this eye. So I hope this was helpful to you, and I thank you for your attention.